is about optimizing PPE during the COVID-19 outbreak. I'm going to start this presentation by saying that this information is based on the most recent guidelines from the CDC and the APIC, Association for Professionals in Infection Control and Epidemiology, as of 19th, 2020. As things evolve, the information that we get may change, and so we will update you with any updated and new information. Talk about first, how does COVID-19 spread? So this is based on, again, the most recent information from the APIC, Association for Professionals in Infection Control and Epidemiology. So it's believed that spreads primarily through respiratory droplets when someone coughs or sneezes within 6 feet. It's believed that you are most contagious when you have a fever and you're actively coughing. So to review respiratory droplets, they are larger droplets that you expel when you're coughing or sneezing. And because they're large, they get pulled down by gravity within 6 feet of you expelling them. That's where the 6 feet comes in. They get pulled down by gravity to the ground, to surfaces. They can also land in the eyes, nose, and mouth. Or if you touch the surfaces, you may also be able to then get them in your mucous membranes, eyes, nose, and mouth. It's also believed that there is increased risk of spread during aerosolizing procedures. So what are aerosols? Aerosols are also respiratory droplets, but they're a lot smaller. They hover in the air for long periods of time. They can travel longer than 6 feet, depending on the movement of the air in the room. So this is where the idea of airborne precautions for COVID-19 is from. Specifically, it's currently believed that during procedures that create these aerosols, the air can go into the air and you can inhale them all the way into your lower respiratory tract. So of aerosolizing procedures are suctioning, extubation, and use of nebulizers. For us, we really just use suctioning and the use of nebulizers. For extubations, we're not going into the room anymore for those. We don't need to be in there when they're doing that, but we do need to be cautious when suctioning and using nebulizers. Evidence of limited spread through contact of contaminated surfaces, but it's not the main way that it spreads. We don't yet know exactly how high the infection risk is of spread through contaminated surfaces, or how long exactly those surfaces stay contaminated. What PPE do we need? We need a gown, gloves, N95 respirator, and protection, or a face shield. I had some questions about shoe covers and head covers. It's not currently recommended to wear shoe covers and head covers. It's not a method that is going to protect you, so it's not recommended at this time. So using N95 respirators if it's mainly thought to spread through droplets, for a couple of reasons. Because the virus is new, we don't have enough epidemiological data, and recommendations for PPE might change as we learn more about the disease. But with enough data, the CDC uses an abundance of caution. So that's why N95 respirators and face shields are currently recommended for any patient contact. But as about before, it's more likely that you would really need the N95 respirator if aerosols are being generated during, so for example, the suctioning or the nebulizer, whereas it mostly spreads through just droplet precautions, which, as you know, for droplet precautions, we just use regular face masks. Do we need to conserve PPE? Yes, there is a global shortage of all PPE, but fortunately the CDC gives us guidance on how to conserve supply. So we're going to go ahead and go through all different kinds of PPE that we have and can use, and how we can conserve that PPE. So they're assist with optimizing our supplies. Our conventional strategies, so that's when you have an unlimited supply of PPE and there are no shortages. And as we're past that now, there are contingency strategies, and that's where we are now. So this is when we anticipate that supplies may be limited and the demands are exceeding our resources. Next level is crisis strategy. So we are at a crisis strategy level, but the CDC does offer guidance on how to use PPE when we are at crisis low levels of PPE. So we're in the contingency strategies. We know that our supplies are going to be limited and we need to conserve them. Strategy level in terms of supplies, so it's the contingency level, and we need to take all necessary precautions to limit and reserve our resources. CDC guidelines and our clinical judgment. So what? Eye protect face masks, right? Masks refers to regular surgical ear loop or procedure masks. Protection face masks and N95s follow contingency guidelines. So here are some general points about conserving PPE. We're going to exclude any healthcare providers who are not essential for patient care from entering care area. We want to use face-to-face healthcare provider encounters with patients as much as possible. We have to exclude visitors to patients with confirmed or suspected COVID-19. One thing we do is cohort patients and healthcare providers. So what does that mean? Cohort a healthcare provider, it means that we can have multiple patients with COVID-19 and one healthcare provider taking care of those patients so that we minimize the amount of staff that are potentially having any contact with a COVID-19 patient. And maximize the use of telemedicine under CMS and federal regulations to the extent that we are allowed to use telemedicine, we will. Protection. We're going to implement extended use of eye protection. So this is the practice of wearing the same eye protection for repeated close contact encounters without removing it. So you can go from patient to patient with the same eye protection without removing it or changing it. It should be processed, which means cleaned. If it becomes visibly soiled or difficult to see through, be thrown away if it's damaged. We should take care not to touch the eye protection while we're wearing it, and if we touch it with our dirty gloves, then we must, immediately perform hand hygiene, or if we touch it with our clean hands, we need to immediately perform hand hygiene. We should leave the patient care area before we remove our eye protection. Just a note that disposable eye protection can be cleaned and used as long as designated to only one healthcare provider. So how this works in practical terms is currently we have shields that are plastic. They are intended to be disposable, but we can reuse them. So they're to like a surgical mask. How it would work is you put your N95 on, you put face shield that's attached to your surgical mask on over your N95. And, I have tested this out. The face shield does wrap around nicely on both sides of your face, and it offers good protection. So after you see that patient with your face shield on, you can take that face shield off and clean it for reuse, but it must be labeled with your name to make sure that only one healthcare provider is using that PPE. Okay, face masks or ear loop or procedure masks. Now, just a note, right now we are using N95, not the face masks or procedure masks. But if you have a patient who's under droplet precautions for something else, we do need to conserve those ear loop face masks. So we are going to implement this for any patients who are under just strictly droplet precautions or any time that we're using an ear loop or surgical face mask as going into a facility. So we can extended use of face masks. This is where we wear the same face mask for repeated close contact encounters without removing it between encounters. So we can go into our facility, we can see multiple patients with the same face mask on. We should remove or discard the face mask if it's soil damaged or hard to breathe through. Take care not to touch it. If you touch it, adjust it with clean hands, perform hand hygiene. And leave the patient care area before you remove your face mask for those that are in, droplet precautions. You, at this time, restrict face masks to use by healthcare providers rather than giving it to patients for source control. So previous recommendations said that we could put a face mask on the patient. However, now that we are in a contingency plan to conserve our supplies, we need to reserve those face masks for healthcare providers. If the patient has symptoms of respiratory infection, they can use tissues or other barriers to cover their mouth and nose. And there's really to how many times we can use our face masks at this time. Non-sterile disposable patient isolation gowns are appropriate for use with COVID-19. Now, we are not reusing our disposable patient isolation gowns. The contact is the least not thought to be the main way that COVID-19 spreads. So, having an isolation gown is very important for high contact activities like bathing, transferring, incontinence care, wound care, definitely suctioning, or if you're giving a nebulizer. But if you're briefly going in the room, do you need a gown? No, we want to conserve those gowns for those who are actually caring for the patients. So we're going to use the disposable patient isolation gowns at this time, and we are going to dispose of them after use because they fall apart when you take them off. Anyway, the size rip and everything. A majority of our isolation gowns don't have a manufacturer designated shelf life, so there's no expiration date. So we are extended use of isolation gowns. We can use the same gown for cohorted patients. So let's say we have 2 patients in a room, or let's say we have a wing designated to the COVID-19 patients. We're moving between patient to patient, and all these patients have COVID-19. We do not need to change our gowns in these patients unless one patient is in isolation for a different disease requiring contact precautions above and beyond COVID-19. So let's say one of those patients has C. diff, then yes, we would need to change our gown after caring for that patient because we wouldn't want to give C. diff to the other patients that are just in for COVID-19. So the gown is visibly soiled, of course, we'll remove and discard it. I talked about prioritizing gowns for those who are doing high contact physical care of the patient. Now we'll look at our N95 masks. So they recommend using a combination of the below approaches to conserve our N95 masks. The point we're going to use alternatives to N95s when feasible. Currently, we do not have any alternatives to N95s, but as supplies become available, that may change in the future. We just have to keep seeing how the situation evolves. An alternative to a N95, an example would be something that's higher rated than an N95, like some of those hoods that you might see pictures of people wearing, or those big face masks that people wear. Okay, so implement extended use of N95 respirators. This means we can wear the same N95 for repeated close contact without moving the N95 between encounters. So again, we can go from patient to patient where we're caring for multiple patients with COVID-19. We can go from patient to patient with taking off our N95. We cohort our patients with COVID-19, so put them in the room together or put them all in rooms next to each other in one designated area. Now, I want to call your attention to this next point that says no more than 8 hours of continuous or intermittent use of the N95. So there have been some news stories and things shared on social media that in some areas, healthcare workers are using N95s for more than hours at a time, multiple days in a row. Where we're right now is we're in the contingency plan, so we're not in a crisis plan right now. So that means that we are going to go with the CDC guidelines and the manufacturer recommendations just use our N95s for only 8 continuous or intermittent hours. So if you use it, let's say you're using it for 6 hours, you're wearing it for all 6 hours, and then you take it off to go have lunch for half an hour. When you put it back on, you can use it for 2 more hours. And implement reuse of our N95 respirators by one healthcare provider for multiple encounters. Move it after each encounter. So let's say we have one patient with COVID-19 and other patients who do not have COVID-19. So we can care for our patient with COVID-19. We can take our N95, label it, hang a designated spot, or put it in a brown paper bag labeled. And we do hand hygiene, and then we can care for our other patients, come back and put that same mask on, as long as it belongs to one single health care provider. So can we remove that N95? Right now, the limit is up to 5 times of removal, of putting it back on. Of course, it should not be shared. It should be labeled. Talked about hanging it in a clean storage area or a paper bag. To modify it, we don't want to put anything inside that paper bag when we store it or bit. And of course, always do good hand hygiene after removing our N95 mask. To put a used mask back on, we want to put clean gloves on before we touch that mask and put it back on. About N95s. So if we are using our N95 respirator to care for a COVID-19 patient who is undergoing an aerosol generating procedure, so again, suctioning, extubation, or nebulizer treatments, if we're 95 during that scenario, we would want to discard it after that procedure in this plan. And also would want to discard it if it is contaminated with blood or any secretions or body fluids. Discard it if we have close contact with or exit from the room or care area of a patient who's co-infected with another disease requiring contact precautions like C. diff. Consider use of a cleanable face shield on top of an N95 and others to reduce the contamination of our N95. So currently using our surgical mask face shield over top of our N95, and that will protect the N95 from becoming contaminated. You want to perform after touching or adjusting your N95 respirator, and obviously discard it if it becomes damaged or hard to breathe through. I just about breathing through N95s. Did do a study during the SARS outbreak. Healthcare workers who wore N95s for prolonged periods of time, 8 to 12 hours, and they found that there was no impairment as far as those healthcare workers' breathing, oxygenation, CO2 levels. It was perfectly safe to breathe through an N95 for an extended period of time. However, psychologically, some people really do struggle with keeping the N95s on and sealed for long hours. And for those people, if they start to feel claustrophobic or like they can't get a deep breath, they'll start, just even unconsciously sitting with the mask, adjusting it, moving it, and then they could, the mask doesn't have the integrity that it when it's properly fitted. So for those people who are really kind of struggling with keeping it on for long periods of time, they should schedule breaks where they can take it off and go, take some deep, get some air, and come back. So in summary, this is our contingency strategy during the pandemic. We're not in a crisis strategy, but as things change, our recommendations may change. We want to take immediate action to conserve our supplies and prevent the use of our supplies to the next level. Should things change, we'll be here to update you, and we will continue to use the CDC guidelines and our clinical judgment for the use and safeguard of our supplies. I also want to reiterate that we're very committed to protecting all of the frontline staff as much as possible, and we are following the CDC and Department of Health guidelines to a T. collaborating with epidemiologists and infectious disease specialists in order to protect all of our staff and minimize any risk of exposure. At the same time, we want to conserve that PPE so that we can continue to protect our staff for as long as possible. Thank you so much, and please, as always, call us if you have any questions. The Command Center line is 227-5147.